All right, good morning everyone, and welcome to the Individualized Treatment and the Non-Pharmacologic Components of Recovery webinar. I'm so glad that you could join us this morning. I'm your host, Susan Halpin. I'm the Education and Outreach Coordinator for the New England region of the National Networks of Libraries of Medicine. So I just wanted to let you know that this webinar is being recorded, and shortly after the webinar ends, you'll receive a link to the recording and presentation slides. It probably will be a couple of days, and as long as you registered for the webinar, you'll be on our list to receive the recording link. If you would like to view this webinar with captions, the URL is located right above the picture in the center of the screen. All right. So our second slide here, oops, why am I not advancing? There we go. These are just some common myths about substance use disorder, and if anybody has any thoughts about any of these myths, you can put them in the chat box and perhaps we can discuss some of these if there's time. So, as I said, I'm your host, Susan Halpin. I am the Education and Outreach Coordinator for the New England region of the National Network of Libraries of Medicine. Our presenters have put together a great presentation with a large amount of information about individualized treatment for addiction. So the format of this webinar will be as follows. I'm going to just give you a brief overview of the National Library of Medicine and the network, which is how we provide outreach. And then our speakers will be giving you a presentation for about 45 to 50 minutes. They said that they're comfortable taking questions while they speak. So if you have a question during the presentation, please type it in the chat box, and I will try and monitor the questions, and we'll try to get you some answers. So the learning objectives for this morning's webinar is to become familiar with the National Library of Medicine and its free digital resources, understand how the NLM provides outreach by the National Network of Libraries of Medicine, or NNLM, through comprehensive online resources, training classes, and grant funding opportunities. We also hope you'll come away with an understanding of the rationale and treatment options for managed withdrawal of a patient with opioid use disorder. We also hope you'll understand the rationale and treatment options for medication-assisted treatment in a patient with opioid use disorder, and understand the non-pharmacologic components that are part of recovery. So this slide is just a brief overview of the National Library of Medicine. It actually is a physical library with the building is in Bethesda, Maryland, and it's part of the National Institute of Health campus. It's the largest biomedical library in the world and is one of the federal government's largest providers of digital content. The library is open to everyone, and all of its resources are free. All of its resources have been put online, so anyone who has internet access can access these resources. They're health and medical resources for a wide variety of audiences, you know, including healthcare professionals, public health workers, consumers, teachers, librarians. So the National Library of Medicine implements its outreach through a network. So it has a nationwide network of health sciences libraries, public libraries, and information centers. You can see on the map there are 8 regions, and each of the regions has a partnership with a regional medical library. And this outreach is provided through the online health and medical resources. We also do many free training and professional development classes like today's class, and we also provide grant funding opportunities. This is just a screen about the network, and nationwide the network has about 6,800 members. Those are just people who have decided to join the network. Anyone can join, it's free, and when you join the network you have access to those free training classes and also grant funding opportunities. And there's a link at the bottom. If you're interested in joining the network, you can explore that through the link. Okay, so the New England region is very fortunate to have Dr. Gerardo Gonzalez and Lindsey Silva, who are going to be talking about their experiences with the creation of a new addiction treatment facility in Worcester, Massachusetts called Washburn House. Dr. Gonzalez is the medical director of Washburn House, and Lindsey Silva is the director of quality and compliance. And they'll give you a little bit more detail about their backgrounds. So I'm going to turn the presentation over to them. Let me just... And Lindsey, are you there? Oh. Okay, Lindsey, are you there? Or Dr. Gonzalez?
Okay. So
okay.
Here we go. So welcome, good morning, and welcome everybody to our webinar. We hope we're going to have a good time discussing for better understanding the non-pharmacological components that are part of recovery. So I'm Gerardo Gonzalez, the medical director, and Lindsey Silva and I are going to be sharing this time with you guys. So in addition to being the medical director of Washburn House, I'm the director of the Division of Addiction Psychiatry and the associate professor of psychiatry of the University of Massachusetts Medical School. And I'm originally from Colombia. I've been in the United States since 1996, and I was trained in the UK, and then I was trained in Yale, and now I've been with UMass and in this region since 2008.
Yep, and Lindsey Silva here. I am a registered nurse. I have my master's degree in public and community health nursing, and I work as the director of performance improvement, quality and compliance at Washburn House, which is a new substance use disorder treatment facility in the city of Worcester.
So here are our disclosures. We have no financial conflicts to disclose. We will review some evidence-based off-label use of some medications, and we wanted to let you guys know. This is the way. And here's our outline of what we're going to be discussing today. We're going to review briefly the epidemiology of opioid use disorder. We're going to talk about some preventive efforts that are needed to try to deal with the opiate epidemic that we're dealing with in the U.S. We're also going to be talking about treatment, stabilization unit, and medication-assisted treatment. We're going to look at some longitudinal outcomes related to opiate use disorders. Basically, a study done in Australia, which I think is relevant for some of the points we want to make. And then we're going to talk about recovery elements and then some conclusions. Like we said at the beginning, as we go along, if there's any question or any clarification that people want, please let us know, and we'll try to address them as we go. So in terms of epidemiology, this is data from the National Survey of Drug Use and Health, 2014. And as you can see, that this is past month illicit drug use. We have in the United States back then we have 10.2% of patients. Can somebody mute their? We can hear somebody typing. Can somebody mute it so that we don't hear it all? So going back to the presentation. So this survey asked patients in their household, have they used substance use within the last lifetime, the last year, and the last month. Here we're looking at the opiate substance use reported in the last month. And as you can see, 27 million people, or 10%, said they had used at least once, and the month before, and we see 0.4 people said they had used heroin itself, and 4.3 million of people had used pain relievers. This is back in 2014 when the epidemic of opiate use, the epidemic of opiate use was starting. And here we have evidence from the CDC 2016, and you can see the death by drug overdose of opiates is the first line, and it's been going up since 2000 and 2014, and it keeps going up 2016, 15, and 16. And then you see the breakdown. Heroin has from 2012 has had an increase and of being responsible for some of the deaths that we are having. This is a study done by Captain, published in the New England Journal of Medicine, and you can see here the prescription opiates and heroin drug poisoning from 2000 to 2014. You see them both going up, and heroin actually having an increase from 2010. Wait up. Listen, I just hit it twice. Okay, well, let's start here. All right, and so here with the medical students in the Worcester area, we looked at everybody who had died of an opiate overdose within the Worcester metropolitan area, and there were 157 deaths by opiates from 2008 to 2012. Of those, we went back to the medical record in UMass Medical Health Center, which is one of the major healthcare systems here in this metropolitan area, and we went and looked at who of those who had died had actually a diagnosis of opiate use disorder, or they were being treated with opiate analgesics and they had any aberrant behavior, and we classified those that met that criteria, or haven't had a diagnosis of opiate use disorder, or haven't had any aberrant behavior, meaning they've been prescribed an opiate, but they've been losing the prescription, they've been calling to get early refills. And so that we split the two populations, and problematic opiate users, which are the blue, and those who had died but did not have any documentation in their electronic medical record of having any opiate use problems. Now, this is key because when we went to look at these, we were expecting that we were going to have 80% of people dying of opiate overdose, have an opiate use disorder, or at least some evidence that they were being prescribed opiates, but we found that 50% of them did not. And what we're looking at here is what were their diagnoses. So the blue, you can see that they had an opiate use disorder diagnosed, or they had a substance use disorder, or they had, those are the two big ones. Whereas the red ones, the non-problematic opiate users, they had some mental health was more significant, mental health issues, and they had chronic pain. Now, the average age was around 40. Most of them were Caucasian men. And something important in terms of prescription, the morphine equivalent of opiates for the ones that had a clear diagnosis of opiate use disorder was significantly higher than the other group that did not have that. So it's sort of a group that is of interest right now to try to figure out what happened. And one of the possible explanations is that these opiate overdoses could have been intentional overdoses, and that's what we're going to try to figure out. Of all the ones that we looked at, 157, there was only one that was documented as a suicide. All the other ones were not documented, but that's, like you probably know, it's very difficult to do retrospectively. And then we have here, what was the last service they saw? So these were, we looked at patients who had been seen in the last year. So they died in Worcester, and we went and see who were seen in the last year in our medical center. And these were the services where they were seen by the two groups. The problematic opiate users were more likely to be seen in the emergency department, which is expected, and an inpatient medical and in psychiatry, whereas the non-problematic opiates were probably in surgical or subspecialties and in primary care. Now, this is a graphic that helps us understand where is the opiates coming from. And as you can see here, the blue pie, which is the left pie, that's, they got 54% have, when they were asked where they obtained their opiates, they say they get it free from a friend or from a relative. And those that got it free from a friend or a relative, they were prescribed by one doctor. 81% were prescribed by a doctor, probably for a legitimate reason. But like we know that probably people don't take it, they store it wrongly in cabinets, in medicine cabinets with not locked, and that's where people can get access to them. Actually, one patient that I had some years ago would go shopping to open houses and open in medicine cabinets looking for opiates. That's how he got his supply. So that sort of represented pretty much what probably was happening. All right, so that in terms, sort of an overview of some of the epidemiology. Now, in terms of the substance use disorder criteria, you probably had heard of this in other presentations, but I just want to summarize it again. So substance use disorder, and specifically opioid use disorder, is a maladaptive behavior after 1 year of opiate use disorder. And I like divided in these three components so that you can picture it. One is some neuroadaptation, second is some cognitive distortion, and third, some behavioral discontrol. We usually it's easier for us to see behavioral discontrol, somebody using drugs or somebody saying that they're having a hangover or they're having some problems. But the two first ones are also important to think about. So tolerance means, like you probably know, you take the person takes the substance, they start on a lower dose, and as time goes by, they need to increase the dose to get the same effect. Or if they keep the same dose, the effect reduces. Second, when the person has been taking opiates for a while and they stop using the opiates, they develop a characteristic opiate withdrawal syndrome that is characterized by like having a bad flu with watery eyes, running nose, muscle aches, diarrhea, vomiting. So that's the withdrawal of opiates. And then we have some cognitive distortion. As the person starts to become more dependent on the substances, the importance of substance use starts to become paramount or salient. At the beginning, they were used maybe. At the beginning, they were used here and there for reasons, for partying or curiosity. But as they become dependent, they start using daily, and then it becomes very important for their daily activity to get substance to use the substance. The second one is subjective awareness of decreased control. Some people call this lack of control, that they can't stop their use, but usually people are aware that they initially were able to use it when they want it, but then after, when they develop it, it starts to become an issue, and they can't control their use. They have to use it every day, even if they don't want to. And then this is a new criteria, the craving or strong desire to use the substance is also something that develops over time, and it's sort of now a criteria for the diagnosis. And then the behavior discontrol is obtaining, using, and recovering, using despite knowledge of the problems, using more and longer than intended. And if you can see that last one, using more and longer than intended, is sort of the behavioral component of the decrease of control. So they're sort of their, if you wanted, they're a mirror. Now, something important about opiate use disorder and the diagnosis is tolerance and withdrawal. If the person is being prescribed an opiate for pain management, obviously that the two criteria of tolerance and withdrawal shouldn't apply for the diagnostic criteria, because as we know, if somebody's taking those medications, after a while they develop tolerance, they develop withdrawal. So you have to think about the other elements of the dependence of the substance use disorder to be able to say if somebody who's being prescribed an opiate for chronic pain, you can have an opiate use disorder. And then I also highlighted here the craving or strong desire to use, because that's a new criteria that wasn't included in the DSM-IV.
This is today's topic.
Okay, in terms of preventive efforts, I like to include this because this involves all of us. And as you can see in the slide as it shows, what are the preventive efforts that are occurring right now that are important to try to decrease the opiate epidemic? One is education of medical and nursing students on the universal precautions with the prescription of controlled substances, and that is happening now in medical schools and nursing schools, so that the new health professionals are more aware of how to be careful with the prescription of medications. Second, there is now prescription guidelines for practicing physicians and dentists to safe manage pain. Now, pain needs to be treated, but it needs to be treated in a careful way, in a safe way, so that patients get the benefit of the medications when it's needed, but they don't get too many medications that they're left around and that can be used. The third effort is the prescription monitoring program that is right now mandatory in most of the states in the United States, that before you prescribe a controlled substance, that you need to go onto the website and verify that that person is not being prescribed by another physician, and if they are, then to try to help that person manage their basically doctor shopping. Hey, sorry, there's somebody who has an open mic, and it's really disturbing. Can you please put it off? Thank you. And then safe storage of opiates. This is very key, because as you saw, most of the opiates that were going into the hands of our youngsters and of the patients who are dying of opiate use disorder, they were basically getting this in cabinets. So the recommendation is that if you get prescribed a controlled substance in a locked box, and make sure that you keep it away from children, and you keep it away from patients, some other visitors who can access.
Excuse me, somebody is typing. Please mute your line.
All right, and then appropriate disposal. So if you have leftovers after you get a prescription, after you get a prescription.
Oh my God, people are so rude. Okay,
After you get a prescription, if there's leftovers, then you need to know, and this is where education of everybody and everybody on this call can educate others, is that this appropriate disposal of unused opiate analgesics is clear. One, there is police that you can take them to. Some pharmacies are now having a box where you can just go and dispose them there. The police also are having collections here and there. But number three, although sounds, is that if this fails and you don't have that available in where you are, then you can dispose them in the toilet. I know it sounds that you shouldn't be doing that, but between throwing them in the garbage and throwing them in the toilet, it's still safer to throw them in the toilet and get rid of them, and not even hanging around, which is what's been dangerous. And then the other preventive effort is naloxone rescue kits are available. We have standing orders in some pharmacies, but we're teaching bystanders, family members, how to recognize somebody who has an opiate, who's an acute opiate overdose, and how to use the naloxone rescue kits at the same time as they call 911 to make sure that they save people from dying of an opiate overdose. Okay. Now, in terms of treatment, so in terms of treatment for opioid disorder, we have medications that are helpful, and then we have non-pharmacological interventions. In terms of services that are available to help patients with opioid use disorder, this graphic, I think, represents the majority. So the blue columns are outpatient treatment. The red is residential, non-hospital, or what we call clinical stabilization units. The yellow is hospital inpatient when somebody has a severe opioid withdrawal or they have medical complications or psychiatric complications. And then we have the green diamond and line showing medication-assisted treatment with methadone or Suboxone. Now, so methadone, we have a limited number of slots in the U.S. So the availability of using buprenorphine or Suboxone, so buprenorphine naloxone, which is a combination of buprenorphine and naloxone, and office-based and training physicians, and now we're going to have physician assistants and nurse practitioners also be trained. We're hoping by doing that, we're going to be able to increase access to this treatment, which is one treatment. It's not the gold standard, but it's one treatment, medication-assisted treatment for opioid use disorder. Now, here are the different services that we have to treat substance use in general. Detoxification or stabilization units, which we call ATS, inpatient acute hospitalizations, non-hospital residential rehabilitation, that's CSS, partial day hospital programs, intensive outpatient programs, and outpatient treatment or office-based treatment for Suboxone specifically. Here at Washburn House, we have right now ATS, we have a CSS, we have a partial hospital program, and we have intensive outpatient program. We are planning to develop a more outpatient treatment with office space, but that is at the point it's in plans. And here are the psychosocial interventions that are used across different substances: drug counseling, motivation enhancement, relapse prevention, cognitive behavioral therapy, mindfulness-based treatment, contingency management, 12-step facilitation, and we always include self-help groups as part of treatment plans. And there's good evidence that a combination is going to be more effective than just one approach. Now, the use of medications for opioid use disorder, we usually in two contexts. One, we use it as And for acute, when somebody wants to stop using heroin or wants to stop using opiates, we use it to try to manage the opiate withdrawal, and we do that in stabilization units. Now, something important that I want to say before I move on to that is that if somebody has an opiate use disorder, they do not have to do a detox before they can be treated with medication-assisted treatment. The only exception to that is that if somebody wants to get on naltrexone, which is a blocker of Vivitrol, they can do it ambulatory. It's a little more challenging because they need to stop using opiates at least a week before they get the injection. So sometimes it's very convenient to just do the stabilization for a week and then go ahead and start the naltrexone. But for methadone or Suboxone or buprenorphine, they don't need to do a detox, and that's important to understand. Now, in terms of managed withdrawal or detoxification, which somebody is more widely known, the goal of it is to reduce the intensity of the opiate withdrawal, not to suppress the opiate withdrawal syndrome. So it's just to reduce intensity, and it's reasonable if somebody has never been treated before for their opiate use disorder to give it 1 or 2 attempts. However, it should be considered an initial step in recovery, and the research that has been done has shown that the detox is not a standalone intervention. It's an initial intervention that needs more complex engagement to be able to be effective. The effectiveness of just doing a detox is less than 20%. So that's why just doing a detox and going back to what they were doing before with the hope that they're somehow not going to use anymore is really not realistic. The efficacy does improve if doing a detox, they engage in an intensive outpatient program or a partial hospital program. That increases the chances of somebody who does not want to do medication-assisted treatment after a detox to be able to remain abstinent and start the recovery. And like I said, ATS is not necessary to start a medication-assisted treatment, which is that last point there. Now, what medications do we have? So some stabilization units just like to use one protocol. We have decided that we want to use for opiates 3 protocols. We want to be able to educate the patients who are coming in and offer them 3 options and have a discussion. Now, we do think that personal preference is going to be a motivation factor, but some patients need to be educated. So it's an interaction between what the patient wants, but the patient has received in the past. And if it makes sense to go with their preference, then we go with their preference. But if not, we have let's say a discussion and a joint discussion to try to make the decision that would serve that person a better chance of moving on to the second step and not just stopping the opiate use and then going back and going back to what they were doing before relapsing. So we have a clonidine protocol. Clonidine is an alpha 2. It's not an opiate. It's not an opiate one. And so some patients just don't want to be stabilized with opiates. Buprenorphine and methadone are opiates. So we use a clonidine protocol. And also for patients who are interested in stopping their opiate use and getting onto naltrexone, which is a blocker, then this is an ideal protocol. And we have some patients wanting to do that. We're trying to make the protocol short enough so that they come, they stop using opiates, they get on the clonidine protocol, and by day 5, they start getting naltrexone oral, and then by day 8, we're hoping that they can get the injection. And then we have buprenorphine protocol. Buprenorphine is a partial agonist that reduces the severity of opiate withdrawal. We have a 7-day taper to try to help patients stop their use and basically leave without opiate use in a safe and comfortable manner. And then we have the methadone protocol. Basically, we use lower doses of methadone to help reduce the severity of opiate withdrawal, and we taper that off over 5 days. Here we go. Now, so we do think that a joint selection of the protocol is helpful for engagement. It also helps motivation enhancement to try to enhance their understanding that first stabilization is a baby step, and that from the beginning we want them to be thinking what's going to happen after they complete the stabilization, or they're going to go into CSS, or if they're going to go back to their house, or they're going to do an IOP. Anyhow, some more motivation, just not just stopping their use, but moving beyond that. And then some of the challenges that we have been facing is the wide variation of motivation for treatment, and unfortunately the risk of some patients wanting to still use while on the unit. And that's been surprising, but a challenge that we've been hopefully being able to face successfully. Now, in terms of medication-assisted treatment, first, it's an outpatient setting. Patients don't have to be hospitalized for this. The goal is to suppress withdrawal symptoms. In this case, you do want to get to a dose that decreases completely the opioid withdrawal, and sometimes we go a little higher than that. To give an example, buprenorphine, 4 milligrams suppresses the withdrawal symptoms, but we go up 8, 12, and 16 because we want also to decrease the rewarding effect of further opiate use, their craving, and get them stable sort of in a short period on an outpatient basis. So it suppresses craving, and it stops opiate use and relapse, and we adjust the dose to avoid sedation. The sedation usually happens with methadone, so with methadone you need to go up slower because you don't want, you want a person to feel that their craving is decreased, that they're not using, but that they're not over sedated, because otherwise they'll feel they won't be able to function. And again, naltrexone, or you can take it oral or it's an injection. It's a non-opiate and it's a complete blocker of the mu receptor. Then we have buprenorphine and naloxone, which is it's a combination trying to deter patients who have IV drug use or IV heroin use to get the medication and go around and start injecting it, and then methadone treatment. So the important thing to know here is that buprenorphine and naloxone, if the physician PAs and nurses have a waiver, they can prescribe that medication in an office space. Methadone for treatment of opioid use disorder, needs to be dispensed in a methadone clinic by federal regulations. So a couple of things here, I'm not going to go into much detail, but naltrexone, like I said, is used for severe opioid use disorder. It's an antagonist or a blocker. It's another way of thinking about the opiate receptor. If you give it oral, it can be a good treatment for patients who are highly motivated in the past, lawyers or nurses or anybody who really was motivated to stop using and they took it oral, they did well. However, most patients didn't do well because they stop it and they relapse. So since we've had the injection has increased compliance and efficacy. So now it's literally a medication that is an option for the treatment of opioid use disorder. I'm going to share here some of the data that shows it. So on the left, you're seeing patients who had opioid use disorder. This is a study that was done in Russia. And on the A panel, the red is patients who got the injection, 126, and the blue is somebody who got an injection but didn't have the medication. And as you can see, there's a significant decrease on both, but the one that got the injection did significantly much better than the one that got placebo. The other panel, I put it here, is because naltrexone is a blocker of the mu receptor. And the oral one doesn't decrease much craving. And however, this study, they showed that the injection over time decreased significantly the craving. So what we're seeing here is the mean change in craving score. And you can see that the people who got the injection, they decreased their craving significantly more than the ones that got the placebo. Now, that's a little counterintuitive. Basically, it's not very clear from the pharmacological perspective, but the study is showing what had happened. So one possible explanation, at least this is what has been reported by patients who tried both ways, the oral one and the injection, is that when they're taking the oral one, they feel on a daily basis, should I take it, should I not take it? They start with that ambivalence, should I take it? If I take it, I can't use, but if I don't take it, I might use. So every morning is like a battle with their motivation and their readiness for change. And that increases craving, and that basically doesn't help with craving. Whereas when they get the injection, and they know that in the following month, they can't use. And so that takes away that out of the equation on a daily basis. Should I take it or not take it because I already took it? And it looks like that's at least a factor that is involved in the decrease of craving. And then methadone, like I said, methadone is a medication, can only be prescribed in a methadone clinic. It has a very good retention. It still is the gold standard for the treatment of opiate use disorder. The comparisons with buprenorphine still show that methadone has better retention and better efficacy than buprenorphine when they compare head-to-head. But again, the access to methadone is a limiting factor, and there's a good portion of patients who have opioid disorder who, despite knowing the methadone can help, they rather not go to a methadone clinic for some of the other complications of going to a methadone clinic that are not related to the medication itself. And so that's where buprenorphine in an office space has the potential of increasing access to medication-assisted treatment with buprenorphine. And here are the criteria for buprenorphine. You have to be over 18 years old. You have to have 2 failures of detox, one complete history of severe opiate use disorder. Some of the exceptions to this rule are somebody pregnant, somebody recently released from prison, that they don't have to meet these criteria. And this is basically a graph showing the efficacy of methadone versus a higher dose of methadone versus a lower dose of methadone, and self-report, the panel up in the upper panel, and on urines, the lower panel. So so you see getting a lower dose, which is a rate of methadone, versus 82. So a lower dose is 40 to 50, and a higher dose is over 80. And so we do, when you're being treated with methadone, you usually want to use a higher dose, which basically decreases reinforcing effect, decreases craving, and decreases the desire to use. It's more effective. Now, that brings us to buprenorphine, which is a partial agonist. And what that means is that it blocks the mu receptor partially. The combination, now we have a combination of tablet and film. There is in the works, and it's been already approved by the FDA, an injection for a week, subcutaneous injection, and there's another 1 month subcutaneous injection that is going to be available. So that's also going to allow us to use tablet, film, and injection. For now, this presentation is sublingual administration. They have to dissolve under the tongue. They shouldn't be swallowed, because if they swallowed it, you lose the beneficial effect. It has a high affinity and slow dissociation. What that means is that if the person who is using opiates or heroin wants to be treated with Suboxone, they need to be first in some withdrawal symptoms before they can get medicated. Otherwise, the person taking the Suboxone without that condition can have a precipitated withdrawal, make their life worse. And some patients have learned that on the street on the hard way. Now, the regulations of buprenorphine does allow from office-based opiate treatment, and the risk of buprenorphine, despite it's a very safe medication, there are deaths associated with IV drug use and with benzodiazepine use. So it's safe, but it still has some risks. And this is just to remind what I've been saying. It's a graphic talking about the efficacy of what happens with the mu receptor. The antagonist basically blocks it. If you go up higher, nothing happens. Buprenorphine, the higher dose, which goes to the right of that graphic, you get to a dose on the -6, if you see it there, where it plateaus. It has like an effect on the middle range. And the methadone, if you keep going up on the dose, you get a full effect, and if you don't stop going up, you can basically overdose on methadone. So it's possible to overdose and die on methadone, less likely to overdose on buprenorphine, and that gives it some of the safety features. And this is a study that, just to show the efficacy, a study that we did here with heroin and opiate use disorders. but everybody was started on 16 milligrams of buprenorphine, and as you can see, after the first week, most the patients decreased their use of up to 20% they didn't go to 0, which would be ideal, but they went to 20%, maybe using 1 or 2 days from using every day. And what we're showing in this graphic is that patients who have heroin use disorder do a little worse than patients who are dependent on prescription medications, suggesting that 16 milligrams, if you have somebody with heroin use disorder and you're treating with 16 milligrams and they're not doing well, you should consider increasing the dose. And this is to show that what happens with opiate-dependent youngsters. And so this was a study done also initially the sample was 12 to 25, but actually they ended up getting only patients from 16 to 25. And what they were comparing is, until this study was done, it was considered that patients who were really young and have opioid use disorder, they should just do detoxes or the stabilization units. And what they did here was to show that if they do a detox, which is the first baseline, so the group on top, they only got the detox, and then the medication was stopped, and they went and they relapsed. Whereas the patients who got Suboxone and they remained on it, they did much better, significantly better. And then when Suboxone was stopped at week 12, they didn't do that good. Now, based on this study, there is suggestion that even very young persons who have opioid use disorder could be considered for medication-assisted treatment. And it's one of the recommendations. Again, before it wasn't, but now with Suboxone it is. And this is a study. So again, I personally have a difficult time thinking that we need to recommend to everybody, even if they're youngsters, to get on medication-assisted treatment. And I think we need to be doing more studies to try to develop shorter treatments. But unfortunately, we do know that getting somebody on medication-assisted treatment for 3 weeks, 6 months, or a year, and stopping it usually leads to an increased risk, a very high risk of relapse. So what we tried to do with this study was to try to do a combination treatment. We added memantine to buprenorphine, and in young adults, we gave that for 9 weeks, and we stopped the buprenorphine to see if if the combination of these two medications had any impact on relapse. And I'm just showing this figure, showing that those in the line on the top were the ones who got 30 milligrams of memantine in combination with 16 milligrams of buprenorphine, and they were less likely to relapse compared to the ones that got placebo and the ones that got a lower dose of memantine, suggesting that combination might be a line of research development that might help develop treatment alternatives. Now, I'm going to finish before I let Lindsey talk about the other aspects. What do we know about long-term outcomes in terms of medication-assisted treatment? We know that it reduces mortality compared to untreated controls. It decreases in those IV drug users it decreases IV drug use. Those who got medication-assisted treatment after a year decreased it to 29 versus those who didn't get medication-assisted treatment were still using at the same rate. And then HIV conversion, patients who were treated with methadone had a reduction to 3.5 versus 22% of those who were not treated. So we do know that there's an impact in healthcare of patients who have opioid use disorder and get treatment with medication-assisted treatment. And this is a longitudinal follow-up study showing 600 patients who were treated, who were recruited in 2001 and 2002 in Australia. So you see that baseline, those numbers, 99, 98, and 93. That's the percentage of patients having any drug use, which is the purple. The blue line is heroin use, and the red line is meeting that diagnosis of heroin dependence. And this has a baseline, a 3 months, a 1 year, a 2 year, a 3 year, and then 11 years after that. So it basically shows what happens with patients who were treated, and what they did is that all along they were collecting information about treatments that they got, diagnoses that they got. They were concentrating on depression, PTSD, borderline personality, and antisocial personality. And they were also looking at who got detox, how many times, who got medication-assisted treatment, who got residential treatment, and they followed those patients over time, and then they did this analysis that I'm going to summarize, showing what is predictive. Oh, something important about the methodology, for those who like a little methodology, is that they had some fixed factors at baseline, like age and gender and race, but because they had repeated measures, they were also looking at time changes so the impact of variations over time. So let's say if somebody met criteria at year 1 of depression, then they would look at that. But if they were not depressed at year 3, they would also include that in their factor, and they were able to have enough power to show what predicted, or what they were able to show. Okay, this is not working. So in terms of comorbid disorder, this is what summarizes. Major depressive disorder is a predictive factor of worse outcomes. It's the only one that predicts worse outcomes, and that's why the star is there. Antisocial personality, borderline personality, and PTSD are factors, but they were not significantly predictors of less heroin use over the 11-year follow-up. And then in terms of treatment effect, that I find very interesting as well is medication-assisted treatment was not significant. So patients who received medication-assisted treatment didn't. It wasn't significantly associated with predicting use over the 11-year follow-up. However, detox had a negative, actually made it worse. And what the authors were arguing is that in the initial years, there was a positive effect of detox, but in the long run, just being in detox doesn't have a major effect. So that's why the recommendation is detox alone is not a standing alone effect, because they were able to look at as an individual factor. Whereas residential rehab did have a beneficial effect in terms of outcome on opiate use. All right. Good.
All right. So we don't have a ton of time left, and I do want to leave some time for questions. So I will just speak really briefly about some of the non-pharmacologic components of recovery. So what we have up on the screen here is the American Society of Addiction Medicine criteria. This is what the majority of insurance companies utilize for determining the appropriateness of the level of care. And this is also something that we utilize to determine if our treatment in our ATS or CSS or outpatient program is the most beneficial treatment for our patients, or if they require a higher level of care. So these dimensions, dimension 1 takes into account their intoxication and withdrawal potential. Dimension 2 takes into account any biomedical complications. So for example, at this level of care, here, if somebody had significant biomedical complications that we were not able to manage in this setting, they would be more appropriate for a higher level of care. Dimension 3 is emotional, behavioral, or cognitive complications and co-occurring disorders. What we see often is that I would guess around 90% of the patients that we've treated do have some type of co-occurring disorder, whether it be something as common as an anxiety disorder or something as significant as bipolar disorder. So depending on whether they have a mental health condition and its stability, this may not be the appropriate level of care. Also, their readiness to change, their potential for relapse, and their recovery environment are significant factors in determining the appropriate level of care. So evidence-based practice recognizes that treatment should be individualized based on a comprehensive assessment. And I think Dr. Gonzalez did an excellent job touching on the fact that there is no one-size-fits-all treatment, that all of those ASAM factors need to be well thought out to determine if this is the right level of care for these people. For example, if somebody has failed detox, say 6 times in the past year, is putting them through another detox really going to be effective? You know, and then as Dr. Gonzalez highlighted, a detox alone is rarely effective. We're seeing the efficacy to be less than 20%. So offering a continuum of care like we do here allows for more time to address major life problems that required continued work from the individual. We've seen a lot of patients since opening who are homeless, who have legal issues, who have family and interpersonal struggles, may have had children taken away from them, may have DCF involvement, some people that have educational needs or vocational training needs, and just basic life skills. So our case management department is really critical to ensuring that we identify some of these issues that contribute to patients feeling hopeless and contribute to continued use of substances because of those feelings of hopelessness. So in conclusion, the current opioid use epidemic is the responsibility of all to help reduce. Education and change in prescription practices are key elements in prevention. Reduction of diversion and appropriate disposal is important, so educating clients about that is critical. Stabilization treatment alone is not effective. Again, the longer continuity you have, the longer you have to work with someone and address a lot of the underlying issues. Medication-assisted treatments are effective, but there is still need to develop effective short-term treatments. So we'll now open this up to questions. Any questions?
Susan? Susan, it looks like we're done then. What?
Would have been some challenges with being a new facility. Want to talk about that? Some challenges with being a new facility. Well, there have been a lot of challenges with being a new facility. In the beginning, we scholarshiped a lot of patients as we didn't have insurance contracts in place. That's been a really interesting process, hearing about what the insurance companies are looking for. They're really pushing outpatient treatment, but what we have seen is that there are many factors that would make outpatient treatment not appropriate for a lot of patients. If somebody's homeless or if somebody has major transportation issues, it's not really very realistic that they'll be able to attend an outpatient program every day. Things like that really are major considerations, and it's been very, very difficult when insurance companies are restrictive in terms of their willingness to pay for the appropriate level of care. So really educating our staff on the ASAM criteria and advocating for the needs of our patients based on their history has been one of the most significant challenges, just kind of learning this whole industry. Also, just having the levels of care that are necessary. You know, you have such a short amount of time to work with someone. In the stabilization unit, you're looking at an average length of stay from 4 to 7 days. In the CSS, you're looking at an average length of stay of about 2 weeks. So that's a decent amount of time to begin working with someone, but not a significant amount of time to really address a lot of the underlying issues, which is why we are opening our outpatient unit soon. And we have purchased actually another building that will be basically similar to a sober home, but staffed, and that will be housing for patients that are highly motivated and want to continue in our outpatient program. There will be a room and board fee to stay there, as insurance does not pay for a stay at that level of care. The insurance company pays for the outpatient portion, basically. But that's going to give us the opportunity to have potentially an extra 30 days with someone where we can really work on things like vocational training, like life skills, teaching someone how to budget their money, teaching someone how to prepare a meal on a limited income. There are a lot of life skills that people have never learned or need to learn, and having a longer amount of time with our patients will enable us to really address some of those barriers. So we're really looking forward to opening our outpatient. Let me see some other questions here. Are you seeing insurance companies being more willing to cover patients because the epidemic is such a health crisis in our area? Yes, the state does have a 2-week minimum for treatment in a CSS program, but we do still see some insurance companies pushing back on that a bit. So getting extended stays when they are necessary can be a challenge, you know, but we do our best to make that argument, always considering the patient's preference and the patient's need and history.
Okay. You know, since there aren't...
Working with the community president.
What do you mean? You want to?
The other challenge that we have faced open the new is making sure that the community where this is located is understands what is it that we're offering, and that the patients with substance use are patients like any other patient that needs help. Sometimes there's misconceptions and some concerns that opening a substance use program like ours might negatively impact our community, and we've been working with them, and so far things have been going much better than initially we had.
Good point.
All right.
Okay, well, thank you, everybody, for your attention. Thank you for those great questions, and that's it.
You can email us with questions if you have follow-up questions, and we'd be happy to answer them, or even send up some of the references if you wanted details of the reference that we used.
Absolutely. Thank you.
Hello, everyone. Lindsey?
Hello.
Hi. Can people hear me? I hope so.
Yes, I can hear you on my side.
Great. I just wanted to point out, I'm sorry, WebEx is new to me, so I apologize for the noise during the beginning of the presentation. I did just want to let all of you know that the National Library of Medicine has some great resources that could be very helpful with substance use disorder. So the slide here is our new opiate addiction and treatment portal. So there's all kinds of information about understanding addiction, opioid overdose, opioid drugs, medications, prescribing, recovery, data, trends, statistics. And this information is in the format of videos, training courses, government reports, and again, anyone can access this information at this link. And then I also wanted to just mention, this is just a handy tool if you were ever to find a pill and you needed to identify it. NLM has a tool called Pillbox where you actually fill in some of these fields and it will return information about what a pill could be so you can identify it and know what it is. I also wanted to let you know that our site medlineplus.gov is a great place to start if you want to know more about mental health and behavioral health and substance use disorder. Much of the information that Medline Plus links to, such as the mentalhealth.gov site, are partner sites that have been vetted and they're credible peer-reviewed sources to get some great information. I also wanted to let you know that the New England region of the National Library of Medicine actually had started a graphic medicine book club, and we have kits available for groups, and it's a way to offer programming around addiction and recovery. Graphic medicine is they're novels that use a visual format similar to a comic book, and this format can be very effective when trying to communicate about topics that are difficult to discuss. And again, this is a free service, so the information on the slide will let you know how to do this, and all of you will receive the slide packet with your recording link. And then I just wanted to let you know we have a lot of promotional and printable handouts that, again, are free to everyone. And then I also wanted to thank you all for attending this webinar. Thank you especially to Dr. Gonzalez and Lindsey Silva for sharing their experience and knowledge. And the link below the picture is an evaluation link, and it would be very helpful for us to hear your feedback on this webinar, and you will need it if you expect to receive MLA credit for attending. So I'm in the process of planning another series of webinars, and if there is something in the substance use disorder realm that you would like to learn about, I'd love to hear what that is, and maybe we can make a webinar around that information. Okay, thank you everyone. Bye now.